All right, let's get right into it. Today, we are tackling one of the most tested and frankly most high-risk drug classes you'll see on the next-gen NCLEX, the SNRIs. This isn't just a knowledge dump. This is a safety masterclass, all about sharpening your clinical judgment so you can keep your patients safe. Okay, so let's jump in with a classic NCLEX-style question right off the bat. Picture this. Your patient, new antidepressant, is now complaining of a killer headache and their blood pressure is through the roof at 170/95. What are you going to do first? Just tuck that question in the back of your mind. By the end of this, the answer is going to be second nature. So here's our game plan. First, we're going to get the big picture on SNRIs. Then, we'll systematically break down each of the major drugs you need to know. After that, we'll hit the huge safety alerts that apply to the whole class, and we'll wrap it all up with a rapid-fire review and one more tough scenario to make sure this stuff is locked in. Okay, let's start with Section 1, the big picture. Look, if you can grasp the core concept of this entire drug class, I promise you'll be able to reason your way through almost any safety question the NCLEX throws at you. So if you remember absolutely nothing else from this entire explainer, burn this into your brain. This is the #1 rule. SNRIs are fantastic for boosting mood and helping with pain. But, and this is a big but, that N for norepinephrine means you always have to watch their blood pressure, and you can never, ever let a patient stop them cold turkey. This is the foundation for everything. All right, let's get into Section 2. Now we're going to build on that foundation and deep dive into the specific drugs. As we go through these, I want you to pay really close attention to what makes each one unique, and maybe more importantly, what makes each one uniquely dangerous. First up, we've got venlafaxine. You probably know it as Effexor. Here is the critical piece of info. Its effect totally depends on the dose. At a low dose, it's pretty much just acting like an SSRI, working on serotonin. But as you crank that dose up, the norepinephrine effect kicks in hard, and with it, the risk for things like hypertension. The NCLEX absolutely loves to test this kind of dose-response relationship. And this right here, this is venlafaxine's biggest, baddest red flag. Of all the SNRIs, this one is infamous for having the absolute worst, most brutal withdrawal symptoms. I'm talking dizziness, horrible nausea, and those notorious brain zaps. Patients describe them as these brief, awful electric shock feelings inside their head. This is a massive patient safety issue and, you guessed it, a critical NCLEX topic. So knowing that, what is your #1 priority for patient teaching? It all comes down to adherence, right? You have to hammer this home. Never, ever, ever stop this medication suddenly. Seriously, even missing 1 or 2 doses can kick off that awful withdrawal. You have to stress that coming off this drug has to be a slow, supervised process. Next up is desvenlafaxine, or Pristic. You know, the easiest way to remember this one is to just think of it as cleaner Effexor. It's actually the active metabolite of venlafaxine. What does that mean for you? It means it has the same core risks, like hypertension, but its effects are often a little more predictable from person to person. Now for a really big one, Duloxetine, brand name Cymbalta. I'm telling you, if you see an NCLEX question about a patient who has both depression and some kind of chronic pain, like diabetic neuropathy, fibromyalgia, you name it, your brain needs to light up and just scream, Duloxetine. This dual-purpose action is its whole claim to fame. But, and this is a huge but, with that amazing benefit comes a really unique and potentially life-threatening risk, liver toxicity, hepatotoxicity. This is a massive NCLEX safety alert. Duloxetine is an absolute no-go for patients with liver disease or those who drink heavily. So what's the nursing action? You've got to check those baseline liver function tests before your patient ever takes a single pill. So let's apply that. Your patient has cirrhosis from years of alcohol abuse, and a new prescription for duloxetine for their fibromyalgia pops up. What is your first action? You don't give the medication. Your priority is to get on the phone, question that order, and let the provider know immediately. Giving this drug could literally be fatal. Okay, our final drug in this group is Levomilnacipran, or Fedzima. The word you need to connect with this one is energizing. Why? Because it hits those norepinephrine receptors, your body's fight-or-flight chemical, much harder than it hits serotonin. So when you hear Levomilnacipran, I want you to think activation and heart effects. And that leads us right to its biggest risk. While, yeah, all SNRIs can raise blood pressure, this drug is particularly known for causing some serious spikes in both blood pressure and heart rate. This makes it a really bad choice for any patient who already has issues with anxiety or their heart. Okay, we've gone through the individual drugs. Let's zoom back out for Section 3 and talk about the class-wide safety alerts. These are the warnings that apply to every single drug we just discussed. You have got to know these cold. First and most serious is the FDA black box warning. All antidepressants, and that includes every SNRI, can increase the risk of suicidal thoughts and behaviors in kids, teens, and young adults. This risk is especially high during the first few weeks of treatment. This is a top-tier, #1 safety priority. Next up is serotonin syndrome. This is a true medical emergency. The key to spotting it on the exam and in real life is recognizing this classic triad of symptoms. First, mental status changes, like sudden anxiety or confusion. Second, autonomic instability, like a racing heart or wild blood pressure swings. And third, neuromuscular hyperactivity, like tremors or muscle rigidity. Be on high alert for this, especially when a patient is taking an SNRI with other drugs like MAOIs, tramadol, or even the herbal supplement St. John's wort. And here we are, our final section, the NCLEX Rapid Review and Scenario. This is where we put all the pieces together and make absolutely sure you are ready to walk into that exam with confidence. This slide right here, this is your ultimate NCLEX cheat sheet. It boils everything down. Venlafaxine, think massive withdrawal risk. Duloxetine, depression plus pain, but watch that liver. Levomilnacipran, super energizing, so you got to protect the heart. This table is absolutely perfect for that last-minute cram session. And this chart just gives you a really clear visual of that withdrawal risk hierarchy we talked about, which is a classic NCLEX prioritization topic. I mean, look at venlafaxine. It's just towering over the others. Use this image to lock that ranking into your memory. Okay, final challenge. Time to put on your charge nurse hat. Patient A is on venlafaxine. They're in withdrawal, reporting those awful brain zaps. Patient B is on duloxetine, and their latest liver labs, the AST and ALT, are high. And patient C just started levomilnacipran, and their heart rate is 98. Who are you running to see first? Think about it for a second. Which one of these findings is the most immediate threat to your patient's life or organs? Analyze those cues. Prioritize your action. What are you going to do? Now, before I give you the answer, let's look at the common traps the NCLEX sets. They will try to trick you by mixing in an expected side effect with a life-threatening one. They'll test to see if you remember to do your baseline checks, if you ignored dangerous drug interactions, or if you downplay something serious like that venlafaxine withdrawal. Don't fall for it. And here's our final takeaway. The priority patient is B, the one on duloxetine. Why? Because those high liver enzymes, that AST and ALT, that is a direct sign of hepatotoxicity. It means there is active, ongoing organ damage happening right now. And that is a more immediate life threat than withdrawal symptoms, which, yeah, they feel awful, but they're not usually fatal, or a slightly elevated heart rate, which is actually an expected side effect of levomilnacipran. Remember this rule for the NCLEX and for the floor. Actual organ damage always trumps withdrawal or expected side effects.